Chapter 10, Respiration and Artificial Ventilation. Physiology and Pathophysiology. So the mechanics of breathing involve ventilation, which is the process of moving air in and out of the chest. Inhalation is an active process. Your muscles are going to expand, and the size of the chest is going to increase. So the lungs are a negative pressure system, so when that happens, that negative pressure pulls air into the lungs, which is how we get that air in there. Exhalation is a passive process. The muscles relax, the chest decreases in size, and positive pressure is created, which is why the air is pushed out. Some of the terminology that we'll talk about is tidal volume, which is the amount of air that's moved in one breath, and the minute volume, which is the amount of air that's moved into and out of the lungs per minute. Dead space air is air that's moved in ventilation, but it does not reach the alveoli. And alveolar ventilation is air that actually does reach the alveoli. Diffusion is the movement of gases from high concentration to low concentration. External respiration, diffusion of oxygen and the carbon dioxide molecules, or the exchange of gases, between the alveoli and the circulating blood. And internal respiration is the actual gas exchange between the blood and the cells. Cellular respiration is the oxygen from the blood diffusing into the cell, and carbon dioxide is diffused from the cell and back into the blood. So when we've got the patho of the cardiopulmonary system, we're talking about if the mechanics of the breathing get disrupted, the gas exchange is interrupted, or we've got circulation issues, then we're going to look into having system failure and ultimately cell death and system death. So we talk about adequate and inadequate breathing. So the brain and the body cells need a steady supply of oxygen. When they don't have a steady supply of oxygen, this is called hypoxia, or low oxygen levels in the cell. So we need to make sure that carbon dioxide is being continuously removed, or we're going to get what's called hypercapnia, or high carbon dioxide levels. When we're assessing for adequate or inadequate breathing, this assesses how well the cardiopulmonary system is accomplishing the oxygenation and the carbon dioxide removal. So we can compensate for hypoxia or hypercapnia, but we can also predict that this is going to happen too based on the signs that we see. Do we see any shortness of breaths? Do we see an increased respiratory rate and depth? Do we happen to see an increased heart rate? Early on, we're going to compensate. The body's going to work on trying to correct this on its own, and we're going to see steps of adjustment that are going to meet the needs of the body, despite the fact that the body is having some sort of respiratory compromise or challenge. So the body compensating for a respiratory challenge and meeting these metabolic needs happens in respiratory distress. Inadequate breathing is going to occur when the challenge is too great for the body's compensation mechanisms, or when the body can't keep up anymore. This is also going to be known as respiratory failure. Now we need to make sure that we recognize respiratory failure very early on because it's a precursor to respiratory arrest. When you look at respiratory distress, typically we're going to see the use of accessory muscles. We're going to see an increased work of breathing. You're going to see severe or prolonged respiratory distress that is going to eventually go into respiratory failure. And you're going to have that inadequate ventilation when the body has to work so hard to breathe and it can no longer compensate anymore. So then you're going to start seeing a reduced level of responsiveness. They're going to look like they're tired. You're going to start seeing those shallow ventilations and some of the other signs of inadequate breathing as well. So when we go through our patient assessment, when we're looking at signs of adequate breathing, we're looking for and typically going to see a relatively normal mental status, and we're going to see a relatively normal pulse oximetry reading, as well as their skin condition is going to be relatively normal as well. Whereas with your signs of inadequate breathing, you're going to see chest movements that are absent, minimal, or possibly uneven, abdominal breathing or belly breathing. You're not going to be able to hear or feel air at the nose or mouth. Breath sounds may be diminished or absent, and you may have altered breath sounds as well, such as wheezing, crowing, stridor, gurgling, or even gasping. Other signs of inadequate breathing are going to be the rate of breathing being too rapid or too slow, if it's too shallow, too deep, or labored. If you see cyanosis, that bluish color around the lips. Inspirations or expirations are prolonged. You may see in children, they may have retractions where the skin is actually sinking into like their shoulders, their clavicles, their ribs, or nasal flaring where their nostrils flare out and get bigger to try to get more oxygen in. And even low saturations of your O2 reading, less than 95%. Hypoxia is a major cause, and you may see things like patients that are trapped in a fire, if a patient has chronic emphysema, if they've overdosed on a drug that has a depressor effect on it, specifically to the respiratory system, or if the patient has a heart attack. Inadequate breathing, we need to make sure that we're trying to do our best to supply adequate breathing for the patient. So we may need to provide artificial ventilation to the patient that's not breathing so that we can get them back into an adequate breathing stage. So we're going to look at providing supplemental oxygen to the patient if they are breathing, and we're going to look at assisting their ventilations if they're not breathing or unconscious. So at what point do I take action and intervene? So oftentimes our respiratory failure patients will be breathing and they'll be conscious, so we need to figure out what their level of difficulty breathing is. If the breathing's inadequate, we need to make sure that we're doing immediate interventions. ABCs are all life threats, so if we notice a problem in breathing, we need to take that corrective action immediately. So think about what signs might identify the need to intervene in a breathing patient. Positive pressure ventilation. What we're looking at here is that we're forcing air or oxygen into the lungs when a patient has stopped breathing or has inadequate respirations. So this uses force exactly opposite of how the body normally draws air into the lungs, right? Because it's a negative pressure system typically. So the negative side effects of positive pressure ventilation include the decreasing of cardiac output or potentially dropping their blood pressure. We're going to see gastric distension and hyperventilation. So things that we want to consider before we start using positive pressure ventilations. We do not want to ventilate a patient who is vomiting or has vomit in the airway. If we do that, we're going to force that vomit into their lungs and cause aspiration. So if you have to do positive pressure ventilations on a patient who has vomited, you need to make sure to suction the airway clear of all that debris and make sure that there's a clear path. You want to make sure that you're watching for chest rise and fall with each ventilation to ensure that the ventilations are going in, and you want to ensure that the rate of ventilation is sufficient for your patient. Make sure that you're carefully assessing the adequacy of a respiration, and if you can, explain the procedure to the patient. Specifically if they're conscious, but also you want to get in the habit of letting the patient know, even if they're unconscious and you don't think that they can hear you, hearing is typically one of the last things to go in an unconscious patient. So even though they may not be able to respond to you, they may still be able to hear what you're saying. So you want to place the mask over the patient's mouth and nose, and then after getting a good seal on the mask on the patient's face, you'll squeeze the bag while the patient is inhaling. This is when we're assisting their ventilations. A couple different forms of non-invasive positive pressure ventilation. You've got your CPAP, which stands for continuous positive airway pressure, and you've got your BiPAP, which stands for biphasic positive airway pressure. You could do mouth-to-mask ventilation using a pocket mask with a one-way valve, as pictured here. So if you've got a patient without a suspected spinal injury, you want to place yourself directly above the patient's head, apply the mask to the patient, and then place your thumbs over the top of the mask, your index fingers over the bottom of the mask, and then rest the rest of your fingers under the patient's jaw. Basically the modified C and E method for bag valve mask ventilation. You're going to lift the jaw to the mask as you tilt the patient's head backward and place the remaining fingers under the angle of the jaw. So while you're lifting the jaw, you'll squeeze the mask with your thumbs. So you're lifting up with the jaw and pushing down with your thumbs and index finger to make sure that you've got a good seal between the mask and the patient's face. You'll give breaths into the one-way valve of the mask, and you're looking for chest rise. With a bag valve mask, this is your handheld ventilation device. So this is used to ventilate non-breathing patient or patient that's experiencing respiratory failure. Comes in different sizes, your adult, child, and infant bag valve mask with sized appropriate mask on the end of the bag. So the standard features of your BVM or your bag valve mask is going to be a self-refilling shell. It's easily cleaned and sterilized. It's got a non-jam valve that allows oxygen inlet flow of 15 liters per minute. And it's got the non-rebreathing valve, which means they're not going to be breathing in the same air. So the mechanics of the BVM, you want to make sure that if you're applying respirations and mechanical ventilations via bag valve mask, that you hook the oxygen tubing up to a supply of 15 liters per minute. When squeezed, the air inlet is closed and the oxygen is delivered to the patient. And then when it's released, the passive expiration by the patient occurs. For two rescuer bag valve mask ventilation, if there's no trauma suspected, what you're looking at, if you've got two people, it's much easier. You've got one person that can create the seal, and you've got the other person that can actually ventilate the patient. The most difficult part of bag valve mask ventilations is actually getting an adequate mask seal. Everybody's facial features are a little bit different. Some people have facial hair. Everything is quite different from patient to patient, so getting that adequate seal is what is actually the biggest struggle. It's also harder to maintain that seal while you're squeezing the bag. You may move the bag a little bit, you may lift up, push down, whatever the case may be, but sometimes it's easy to pop that seal off while you're squeezing the bag. So in the two rescuer, you've got one person that all they do is squeeze the bag and the other person maintains the seal. Your two rescuer BVM ventilations, again with no trauma suspected, you'll open the airway with a head tilt chin lift. You'll select the correct size bag and mask size. So if they're an adult, obviously you just get the adult bag and the adult mask. You'll kneel at the patient's head, position your thumbs over the top half of the mask, and index fingers over the bottom half. You'll place the apex of the triangular mask over the bridge of the nose and the lower portion of the mask over the mouth or upper chin. Again, your C and E technique, use your middle ring and little fingers to bring the patient's jaw up to the mask, and your thumb and index finger to push the mask down to create a good seal. Second rescuer is going to connect and squeeze the bag, and as the second rescuer releases the bag, the patient should be exhaling, so the chest should fall. If a trauma is suspected, you're going to open the airway using the jaw thrust. Otherwise, the steps are pretty much going to be the same. Just make sure that you're not tilting the head or neck back. So there's the two rescuer bag valve mask ventilation. For one rescuer bag valve mask ventilation, open the airway, select your correct size mask, and you'll use the C and E method. The C with your thumb and index finger. And then you'll use your middle and little fingers to hold the jaw to the mask. Squeeze the bag, and the patient's chest will fall after you release pressure on the bag. If you encounter problems during bag valve mask ventilation, such as the chest not rising and falling, check to reposition the head. See if you've got a broken seal or there's air escaping around the mask. Sometimes if you have a poor seal, you'll also hear a vibrating sound as the air is escaping in between the mask and the skin. Check for any sort of airway obstructions or any obstructions in the bag valve mask system, and also consider the use of some sort of alternative method to supply ventilations. If you have to supply artificial ventilations to somebody who has a trach or stoma, you'll clear the mucus plugs or any sort of secretions from the stoma. You want to make sure that the head and neck are left in a neutral position, and you'll use the pediatric size mask to be able to establish the seal around the stoma. Make sure you're ventilating at an appropriate rate for the patient's age, and if you're unable to artificially ventilate through the stoma, seal the stoma and attempt artificial ventilation through the mouth and nose. A flow-restricted oxygen-powered ventilation device, or a manually triggered ventilation device. This uses oxygen under pressure to be able to deliver artificial ventilations through a mask, which is placed over the patient's face. Remember that this can only be used on adults only. You'll follow the same procedures for a mask seal as you would for a bag valve mask, and you just trigger the device until the chest rises. There's an illustration of that. If you've got a patient that's on an automatic transport ventilator, this provides positive pressure ventilations. You can adjust the rate and volume of the ventilations, and the provider must make sure that the proper respiratory rate and the volume for the patient's size and condition is dialed into the ventilator. There's a picture of the automatic transport ventilator. So think about how you would decide which positive pressure delivery method to use for your specific type of patient. So let's talk about oxygen therapy. The importance of supplemental oxygen. So things to consider when making decisions about oxygen administration are, remember that oxygen is actually a drug. Long exposure to high volumes of oxygen can actually cause harm. Typically, we're not going to see this in the emergency setting, but we do see this and the hospitals have to be careful about supplying oxygen to patients at a high rate for a long period of time. Remember that oxygen should be administered based on your overall evaluation of the patient's presentation and any sort of possible underlying conditions. So we've got portable oxygen, which we use in the field. We carry the bottles with us. They're fairly lightweight, they're safe, and they're dependable. And we've got the installed oxygen, which we see the big tanks that are installed in the ambulance and piped throughout the ambulance for us to use. There's a couple different types of oxygen bottles. Remember, if you're transporting them, put them on their sides. Don't transport them standing up. The tops of the oxygen tanks can actually bust off and create a rocket, basically. There's your large cylinders that are fixed and strapped into the ambulance. Different size of oxygen cylinders. We don't really expect you to know what size and how many liters of oxygen they carry. Just know that they do come in different size. The oxygen cylinders are going to use pressure gauges, regulators, and tubing, and these are intended for use with oxygen and oxygen only. We use non-ferrous wrenches to open the oxygen tanks up. We want to make sure that we've got a good valve seat in the inserts and the gaskets are in good condition. And remember to always use medical grade oxygen. You'll want to open the valve of the oxygen cylinder fully and close it half a turn and so this prevents someone else from thinking that the valve is closed and trying to force it open. Store any reserve oxygen cylinders in a cool, well-ventilated room and make sure that they're properly secured in place. And have the oxygen cylinders hydrostatically tested every 5 years to make sure that they're still safe to operate. Never drop a cylinder or let it fall against any object. Make sure that you never leave an oxygen cylinder standing in an upright position without it being secured. And never allow smoking around oxygen equipment that's in use. Make sure that you never use oxygen equipment around an open flame. Never use any sort of grease, oil, or fat-based soaps on devices that will be attached to an oxygen supply cylinder. Never use any adhesive tape on a cylinder. And never try to move an oxygen cylinder by dragging it or rolling it on its side or bottom. For pressure regulators, they're going to be connected to the oxygen cylinder to provide a safe working pressure of 30 to 70 psi. Flowmeters, these allow the control of flow of oxygen in the measurement of liters per minute. So you've got your low pressure flow meters. It's going to be pressure compensated flow meter to allow a constant flow through the selector valve. And then you've got your high pressure flow meters such as your thumper CPR device and respirators and ventilators such as CPAP and BiPAP devices. There's a couple examples of flow meters. The one on the left is typically what you see on the wall of the ambulance, so you can select the right rate. The one on the right is typically the one that you're going to see on an oxygen tank on a portable delivery system. This one's your high pressure flow meter. If you need to deliver high pressure oxygen, you're going to use the valve coming out just below the display valve. Humidifiers, these are connected to the flow meter and it moisturizes the dry oxygen from the supply cylinder. Typically people who are on home oxygen or on oxygen for a long period of time will have a humidifier because that dry oxygen can really dry out your mucous membranes, and the humidifier will help keep those moistened. There's your humidifier for use of the onboard oxygen supply. Some of your hazards you're going to see of oxygen and oxygen equipment. Okay, if the tank is punctured or a valve breaks off, the supply tank can become a missile. Oxygen also supports combustion, so it can saturate towels, sheets, and clothing. Remember that oxygen and oil do not mix well under pressure, so there can be an adverse reaction if you mix the two as well. Rare medical situations, these are kind of the things we talked about oxygen being a drug and being harmful. Oxygen toxicity. This is exposure to high concentrations of oxygen over a long period of time. Again, this is not something that we would typically ever see in the field due to our oxygen therapy, but this would be something where if we've got a patient on, say, 15 liters of oxygen and they've been on it for a week or something like that, you could start seeing oxygen toxicity or air sac collapse. We want to be careful about flowing oxygen directly into infants' eyes. With kids, small kids, we use blow-by oxygen, but make sure we're not directing that into their eye because it can cause damage to the infant's eyes. Also, in other cases, for high concentration of oxygen over a long period of time, we can cause respiratory depression or respiratory arrest. Basically, the body doesn't have to work anymore because we're supplying the oxygen to it, so it goes into a depression mode or an arrest mode. The non-rebreather mask is the best way to deliver high concentrations of oxygen to a patient who is breathing. Here you see the non-rebreather mask as it's applied to the patient. Note that the non-rebreather mask has round discs on the side. These are flutter valves that allow exhaled air of the patient to escape. That's why it's called a non-rebreather, so the exhaled air escapes, and when they inhale, those flutter valves close and they just get fresh oxygen. So it provides oxygen concentrations of between 80 to 100%. Your optimum flow rate is going to be between 12 and 15 liters per minute. And there's a new design feature in a lot of these that allows for one emergency port in the mask so that the patient can still receive atmospheric air should the oxygen supply fail. Your nasal cannula is going to be the best choice for a patient who refuses to wear an oxygen face mask or just needs very little supplemental oxygen. There's your picture of the nasal cannula there. Your cannula is going to provide concentrations of between 24 and 44%. It's delivered to the patient by 2 prongs that rest in the patient's nostrils, and we want to make sure that we're not exceeding 6 liters per minute. A partial rebreather mask is very similar to a non-rebreather mask. However, there's no one-way valve and opening to the reservoir. It delivers about 40 to 60% of oxygen at a flow rate of about 9 to 10 liters per minute. Your Venturi mask, this delivers specific concentrations of oxygen by mixing oxygen with your atmospheric air or your inhaled air. Some of these have set percentage and flow rates, and others have an adjustable Venturi port. There's your Venturi mask. Your tracheostomy mask, this is going to be placed over the stoma or tracheostomy tube to provide and allow for supplemental oxygen. You're going to connect this to oxygen supply and run it at about 8 to 10 liters per minute. There's a picture of your tracheostomy mask. Special considerations. Think about if your patient has a facial injury. Bleeding and swelling can disrupt the movement of air. So we may need to go for aggressive suctioning, and we may have to consider advanced airway maneuvers to be able to keep the patient's airway open and keep them breathing. Any obstructions? Foreign bodies can impede ventilation of the patients. Foreign bodies and the tongue are the top 2 areas of respiratory compromise in patients. If you're unable to ventilate the patient, always consider the possibility of some sort of obstruction. As far as dental appliances are concerned, dentures ordinarily are going to be left in place. If they become dislodged during an emergency, you can work on taking them out. So in most cases, leave it in place if possible, but be prepared to remove it if it starts compromising or looks like it may start compromising the integrity of the airway. Remember, in kids, that hypoxia occurs very quickly. Children tend to burn oxygen at about twice the rate of adults, and this is accounted for by the many anatomical differences that are associated with the kid's airway versus adult airway. So ventilating pediatric patients, make sure that we're avoiding excessive pressure and volumes. We don't want to overinflate the lungs. Use a properly sized face mask. Flow-restricted oxygen power ventilation devices are contraindicated. Remember, these can only be used on adults. Pediatric-sized non-rebreather mask and nasal cannulas should be used. And gastric distension may impair adequate ventilations as it may push up on their lungs. If you're assisting with advanced airway devices, these are devices requiring direct visualization of the glottic opening, such as an endotracheal intubation. And you've also got devices inserted blindly, meaning this is ones that you can put in without having to look into the airway to be able to insert the device, such as the King LT airway. Here you see the advanced endotracheal intubation being done. We're not going to cover intubation in this slideshow. That's a ILS and ALS skill. However, you may be asked to assist in ventilating the intubated patient. So remember that very little movement can actually displace the endotracheal tube, even if it is secured in place. So pay attention to the resistance of ventilations and report any changes in ventilations to your partner. If a patient is defibrillated, make sure that you're carefully removing the bag from the tube as to not dislodge it, and watch for any change in the patient's mental status. If you're assisting with a trauma intubation, you may be asked to provide manual inline stabilization throughout the procedure. So position the hands to hold stabilization, but allow for the movement of the jaw so that the paramedic or intermediate can successfully intubate them. Your blind airway insertion devices, such as the King airway or the LMA, laryngeal mask airway. We don't use the laryngeal mask airway in the field in these areas, but we do use the King LT. Usually do not require the head to be placed in a sniffing position. You can insert these at about any angle. Chapter Review. Remember that respiratory failure is the result of inadequate breathing, breathing that is insufficient to support life. A patient in respiratory failure or respiratory arrest must receive artificial ventilations, and they must receive them immediately. Oxygen can be delivered to the non-breathing patient as a supplement to artificial ventilation. And oxygen can also be administered as therapy to the breathing patient whose breathing is inadequate or who is cyanotic, cool, and clammy. If they're short of breath, suffering from chest pain, suffering from severe injuries, or displaying an altered mental status. Remember to always use proper personal protective equipment when managing the airway. Also remember that the assessment of breathing must be an ongoing process. Respiratory status can change at any point in time. Inadequate breathing requires immediate action. Positive pressure ventilations are very different than normal breathing and can have negative side effects, as we talked about. Remember to select the most appropriate method of positive pressure ventilations based on the needs of your patient. Always use appropriate safety measures when handling oxygen and oxygen devices, specifically tanks, and select the appropriate oxygen delivery device to provide supplemental oxygen to your patient. Some of your questions to consider: what are your signs of respiratory distress? What are the signs of respiratory failure? And for bag valve mask ventilation, what are the recommended variations in technique between 1 or 2 rescuers? How does the way positive pressure ventilation moves air different from how the body normally moves air? Remember how we talked about what kind of system the respiratory system is. Describe a patient problem that would benefit from administration of oxygen, and explain how to decide what oxygen delivery device should be used. And real quick, a couple critical thinking questions. So on arrival at the emergency scene, you find an adult female patient who's semi-conscious. Her respiratory rate is 7 per minute. She appears pale and slightly blue around her lips. Is this patient in respiratory failure? And if so, what signs and symptoms indicate this? Does this patient require artificial ventilations? So yes, this patient is in respiratory failure, and this is demonstrated by a slow respiratory rate, altered mental status, and cyanosis. This patient definitely needs artificial ventilations.